Humans are biologically wired to react to what we can see. If a tumor starts growing on your skin or a simple pimple forms on your face, you notice it, you feel it, you examine it, and you take immediate action. But inside your arteries, a different reality exists. Plaque can quietly build up along your arterial walls for years, triggering localized inflammation and complex biological changes, all without causing a single flinch of discomfort or any visible warning sign. Because there is literally no mirror for your arteries, this invisibility creates a dangerous illusion. We assume that because we look and feel fine on the outside, we must be healthy on the inside. This lack of physical warning means the disease doesn't arrive overnight. It lives quietly within the host for decades, completely undetected. This chart shows the percentage of people whose fatal coronary heart disease presented with absolutely zero prior symptoms. According to the American Heart Association, 50% of men and approximately 64% of women had no warning signs before a fatal event. For millions of individuals, there is no shortness of breath or chest pain to alert them. The very first indication of sickness is a catastrophic event, like a stroke or a heart attack. This is why heart disease is uniquely dangerous. It combines an incredibly high statistical prevalence with total physical silence. Curious, we often associate heart problems with old age, assuming it's a condition that develops rapidly late in life. However, looking at the internal biological timeline tells a different story. Autopsy data from the P-Day study revealed a surprising age of onset. Atherosclerosis, the buildup of fats and cholesterol in the artery walls, is actively present in the majority of adolescents and young adults. It begins early and stretches across decades. The plaque slowly accumulates, driving cellular changes and localized inflammation, all while the body's alarm systems remain completely silent. For most people, the relevant question is not whether this disease will eventually start. The reality is, the process is already underway. Think of plaque as an active biological entity growing beneath the arterial surface, rather than simple debris clogging a pipe. Crucially, a plaque's inflammation and stability determine its risk. A small, volatile blockage is often more dangerous than a large, stable one. When inflammation peaks, the plaque's fragile cap breaks through the arterial surface, spilling its contents into the bloodstream. The body responds to this rupture exactly as it would to a cut on your skin. A blood clot rapidly forms over the site to heal the injury, but inside a narrow artery, that rapid clotting completely halts blood flow. This sequence happens in an instant. It proves that feeling healthy is irrelevant when the internal biology of a plaque becomes highly unstable. To track this hidden process, the current standard of care relies heavily on blood tests. Doctors measure your cholesterol levels, evaluate your blood sugar, and test inflammatory markers to estimate your cardiovascular risk. These tests are valuable, but they have a diagnostic flaw. They only measure circulating risk factors in your blood. They miss the physical presence of the disease itself. This creates a paradox. A patient can have perfect textbook cholesterol levels while harboring highly unstable, deadly plaque. Conversely, someone can have elevated cholesterol and possess perfectly clear, healthy arteries. Blood tests can only tell you the likelihood of a problem developing. Without direct observation, relying solely on blood panels forces modern medicine to make an educated guess rather than a precise diagnosis. The modern medical solution to this estimation problem removes the guesswork. We now have technologies that allow us to look directly inside the arterial walls. Tools like coronary artery calcium scanning and CT coronary angiography accurately map this hidden landscape, providing a clear picture of exactly what is happening in the vessel. These scans identify both old, calcified plaque and the soft, non-calcified inflamed plaque, pinpointing the danger long before a rupture occurs. This animated diagram demonstrates the contrast between the two eras of cardiology. The old method calculated the mathematical probability of a future event based on scattered data points. The new method confirms the actual physical presence of the threat in 3 dimensions. By looking directly at the disease, advanced imaging removes the biological mystery, making a silent threat visible and treatable. If you found a growing lump on your arm, you wouldn't just take a blood test and hope for the best. You would demand to image it, evaluate it, and understand its behavior. Your heart deserves that exact same standard of care. This approach is especially urgent for individuals with a family history of heart disease, borderline blood panels, or those crossing the age of 40. A heart attack is not a random lightning strike from a clear blue sky. It is the end result of a long-term, observable physical process. The threat is common, it is silent, and it is entirely detectable. What you cannot see can hurt you, but the final outcome is now strictly dependent on whether you choose to look.